come and talk to you about exercise this afternoon. So my name is Andy Rapacz. I am an exercise physiologist here at the HealthPartners Neuroscience Center. I'm an American College of Sports Medicine certified exercise physiologist. I'm credentialed as a certified inclusive fitness specialist. I also have the ACSM's exercise is medicine credentials. Those are what those letters after my name mean. And I'm here to talk today about exercise and what that might look like after stroke, but really trying to answer like why is exercise important? Why after stroke is it important? What might make it harder? And how might we approach exercise differently after we've had a stroke? So here's some facts. This is like the doom and gloom part. You get the bad news first. So these are direct from the American College of Sports Medicine's Exercise is Medicine initiative. Exercise is Medicine is a global initiative sponsored by the American College of Sports Medicine that was really trying to promote the value of exercise and physical activity in the context of healthcare, right? There are all these things that we say about exercise that we know it's good, but what does that really mean? So here's some facts. I'm going to read these to you because I think it's important. So nearly half of U.S. adults, 46%, do not meet the recommendations for aerobic physical activity, and nearly 1/3 report doing less than 10 minutes of moderate to vigorous physical activity per week. So that means that most of us aren't moving a whole lot, right? If only half of us are meeting the recommendations, then there's a huge population out there that's really living pretty sedentary. So right with that, estimates suggest that individuals spend at least or up to 8 hours a day in sedentary behaviors. 24% of adults participate in no leisure time or no physical activity in their leisure time. So people aren't choosing to be active, right? We spend a lot of time in sedentary activities based on the circumstances of our work, the circumstances of our environment. But then when it's time where we get to choose, we're also choosing to stay sedentary. So we're not choosing to be active when we have leisure time. What does that all mean? Well, we know from research that physical activity contributes to some pretty alarming statistics. So 6% of the burden of disease from coronary heart disease is a result of physical inactivity. 7% of the burden of disease from type 2 diabetes, 10% from breast cancer, 10% from colon cancer. And right, these are just things that we've researched, and we know we can assign a percentage to these specific disease profiles. Overall, we know that inactivity causes 9% of premature mortality, or more than 5.3 million of the 57 million deaths that occur worldwide.
That's
so
staggering.
Pure inactivity, right, just because we're not doing something, is a pretty significant factor in why people are dying, right? 1 out of 10 people are dying from things that potentially could be avoided by just improving or increasing their physical activity. That also has an impact on our healthcare system, right? When people aren't moving and they're not healthy, that translates directly to dollars, right? This is not only a public health issue, but from a financial standpoint, our healthcare system just isn't set up to carry the burden in excess from what it's already expected to do just because people aren't active. So $54 billion is the projected or the approximated annual cost to the physical and inactivity productivity. So people not working because of physical inactivity and secondary complications, $14 billion, and then 13.4 million disability adjusted life years. So right, people aren't living as long, they're not living as productively because they're inactive. So that's the bad news, right?
Andy, that's staggering numbers.
It is. It's alarming, right? And it's, it's one thing to say like physical activity is good or like we should do this. But when we actually look at the consequences of not doing it, right? We think of a lot of things as we should intervene so that something gets better, but purely the intervention at a baseline level of just simply doing it, that preventative measure is really important too, right?
Sure.
The good news though, right? We know exercise works. Exercise does all these wonderful things that can help with disease prevention for these various disease profiles. So thinking about cancer, Alzheimer's, stroke, mental health, cardiovascular disease, back pain, all of these things. There's research that shows exercise, increasing our physical activity can have statistically significant improvements in decreasing the incidence and decreasing the prevalence of these diseases. We also know through research that a low level of fitness is a bigger risk factor for mortality than being overweight or obese. So if you're physically active and you're carrying more weight, you're actually probably healthier than someone that's not carrying extra weight, but completely sedentary. So we've heard, you maybe have heard the catchphrase we like to use is fitting is the new smoking. So that sedentary lifestyle, right, is truly impactful on our overall health and wellness. When we know that we have disease too, exercise is one of the easy tools that we can use to help manage it. So cancer, renal disease, sleep apnea, you can read the list here. Right, we know that exercise can help manage these different disease profiles. We just got to find the right ways to do it. Good news, right, is exercise is pretty available, or it should be, right? It's something that everybody can do. So go ask your doctor, right? Prescribe me some exercise. It's unlimited. If we have access to it, we can find ways to do it. These machines that we're given, right? These bodies that we have, they're levers, they're pulleys, they're electrical connections. They work better when we move. So if we can get ourselves moving, everything's going to work better. We just might need to have some guidance on what that looks like. So if you remember nothing else from my talk today, remember 150 minutes of moderate to vigorous or moderate physical activity and 2 times per week resistance training. So the ACSM, the CDC has come out and said that 150 minutes, 2 times of aerobic activity per week, 2 times resistance training will elicit the most benefit overall globally for our population. What we also know is that that's not a zero-sum threshold. If you're not meeting those exercise guidelines, you're still getting benefit. It's not you have to get over that hump to see any benefit, but we know that about 150 minutes 2 times per week for our resistance is what we want to shoot for. And that's a good kind of barometer of where you're at. So if you sit down and think about how many minutes of true moderate aerobic activity are you getting in a week? And are we doing anything to provide some resistance training? Are we doing anything to load to stress our system? So we know that exercise is good. We've decided that there's all these great things that it can do. We've decided that if we don't do it, we're going to cost the healthcare system lots of money and we're going to die, right? But how do we do it after stroke? That's why we're specifically here, because it's different, right? So the barriers for exercise after stroke that we have to bear in mind are, some of them are listed here. So, right, we have organizational barriers. So facilities, right? If after a stroke, we have impairment in our functional abilities, we might not be able to go to a Lifetime or a YMCA, a community gym or a community fitness center, because they might not have the equipment that's necessary for us to be able to exercise. We might not have staff. We might not have exercise professionals that know how to exercise after stroke. There are interpersonal barriers too, right? So you might not think you are able to do it. There's fears, right? The fear of falling, there's the fear of potential injury, motivation. We might not think that it's worth it, right? It's a time value choice that we have to make. So that feeling that it's hard or it might not be worth it to put the time in can be a barrier for even starting an exercise program. There are environmental barriers too. Some of those are harder to overcome. Transportation can be an issue if you're not able to get yourself out to a gym. You're relying on your community or your environment to help get you there. Geography, being close to some place to work out, and then just cultural barriers too. Like exercise, I think culturally is seen as something that we know is good, right? But we're not always willing to take the time or make the investment to do it. But hopefully some of those numbers that we looked at earlier, right, reiterate the importance of this is something that should be medically necessary, especially for these unique disease profiles and the complexities of stroke and the complexities of the secondary complications. The argument should really be made, right, that exercise is as important, if not more important, after a stroke or other neurological diagnosis than before. And then those interpersonal barriers too, right? What does it look like in the community? Or do we have supportive friends, caregivers, working out with other people, right? That accountability can be a super helpful and important part of an exercise program. So things to think about as we look specifically at how we prescribe exercise after stroke. This graphic I like to include, not necessarily because the content's out of this world, but I really like the non-linear approach to looking at our journey after stroke, right? We have a little bit of guidance here that I won't get into with how activity gets introduced along this journey, but what I want to reiterate is that this non-linear progression, right? There's ups, there's downs. Sometimes that progress feels fast. Sometimes it feels like we're plateauing. But the bottom line is we got to keep moving, right? We have to find ways to keep moving. And it's really important that along this journey, right, we have different people, different resources that can help us make those decisions on what level of physical activity is the right level, and incorporating it into an overall care plan. So generally, before we start a physical activity program, we spend some time in a therapeutic setting, right? My friends in speech, my friends in physical therapy and occupational therapy are a part of this journey as well. So a lot of time, physical activity should be introduced through some of these modalities. I like to bring this neuro rehab continuum to kind of contextualize where I fit as an exercise professional, looking at the neural continuum and where some of those handoffs might be and where some of the overlap might be. So after stroke, right, we spend time in that acute setting, making sure that we're medically stable, maybe depending on the severity of our stroke, spend some time in a subacute context where we're not quite ready to be at home, living in the community, but still having some intensive therapy, preparing ourselves for that reintegration into the community. And then hopefully we go see Mickey and our friends at the Neuroscience Center for outpatient therapy, right? Working on some really functional things. After therapy ends, and therapy ends, right, because we've plateaued in functional abilities, or functional change, right? We're meeting specific markers for continuation in therapy, reimbursement, right? We have insurance that might limit our number of visits. Our time in therapy is really finite based on functional progress, functional goals, and reimbursement. Fitness and wellness is a lifelong activity, right? That 150 minutes a week, 2 times per week, resistance, strength activities, that's lifelong. That's across the board. You might get some of that in therapy. Therapy might be where you're introduced to it, but we have to find ways to continue that throughout our lifespan. And after stroke, neurological diagnosis, some of those things get more challenging and some of them get difficult. So it's important to contextualize whether we're working things in a therapeutic environment or if we're operating in kind of the fitness and wellness side of things. So the way that I like to contextualize it is in therapy, your primary goal is for functional improvement. A great secondary benefit of some of the things you might do is you see improvements in your overall health and wellness. In a fitness program, our primary goal is to improve our health and wellness. Secondary benefit of some of the things that we might do is that we see improvements in function. So that relationship should be reciprocal between our health, fitness, and wellness professionals and our outpatient therapy professionals, where we see the need for functional work in that therapeutic environment. We're spending time with PT and OT, but when we're looking at those lifelong maintenance and kind of practicing some of those skills that we've learned in therapy, then that's when we can operate in that fitness and wellness context. So in therapy, you might do gait training, and when you're hanging out with me and working in a fitness program, we're practicing walking, right? Reinforcing some of those skills that were learned, but doing it in a non-skilled context. But it's important to know which bucket we're living in. So I'm going to use this scale when I talk about our levels of activity. So I said we're looking for 150 minutes of moderate physical activity. We like to define moderate physical activity as somewhere between 4 and 6 on our RPE scale. So if we think of 1 as easy peasy, very light, not working hard, and 10 as maximum effort, giving it everything we got, we can scale our rating of how hard we're working. And it's research validated that it does correspond pretty closely to different heart rate zones. So when we look at
Andrew?
prescribing yes.
Got a question. What's RPE stand for?
RPE, great question. RPE is our rating of perceived exertion. So that
Cool.
that 1 through 10 is the rating of how hard you feel you're working. And
Got it.
what we're looking for is corresponding that to these different heart rate zones, which tell us different metabolic pathways, basically give us an idea of how hard we're working. So I'll kind of reference
Good acronym.
this graphic. Yeah, I didn't come up with it. So special considerations, right? As we look at programming our physical activity, what are our deficits? Do we have deficits in strength, deficits in endurance, movement, balance? What are our discrepancies from one side to the other, right? Does our hemiparetic side have a large discrepancy in strength? Is grip an issue? These are all factors in the decisions that we make for exercise, because it might impact what we do, right? If we're going to try to get our heart rate up, get that aerobic activity, but we're not able to walk quickly enough to do so, then we might need to look at some other modalities. And then what are our goals, right? These are things, if we're going to invest 150 minutes a week, we should probably be doing something that aligns directly with our goals. Probably be doing something that's fun or that we enjoy at least a little bit. And then are we really focusing on compensatory strategies, or is that recovery of function our primary goal? We can modulate our choice of activities, our choice of exercise modalities based on what the intent of the activity is, right? So let's choose things that we want to do that support the goals that we have. So I'll go through individually for aerobic, resistance, stretching, and then neuromuscular activity, what the ACSM guidelines are specific for stroke. So 150 minutes, 2 times per week, resistance training, that's our general guidelines. Thinking specific to stroke. For aerobic activity, we want to start with about 3 days a week up to 5 days per week, looking for working out in that moderate heart rate zone, right? So 4 to 6 on our RPE scale, which translates to about 40 to 70% of our maximum heart rate. We can't start right at that 150 minutes, but we progressively want to increase up to 60 minutes per day. And then we have that 150 minutes per week as our baseline exercise guidelines. But that, as we progress and tolerate more, we can push that all the way up to 300 minutes per week. So based on your level of aerobic conditioning prior to your injury, based on your age, based on the severity of your stroke, right? Everybody's number is going to be different to get the greatest effect, but we know that if we can work in the zone that corresponds to that 40 to 70%, 4 to 6 on our RPE scale, that we can receive the maximum benefit of our aerobic activity. What kinds of activities are we choosing? So for our aerobic activity, this is our prolonged rhythmic activities, whole body activities, things where we can get our whole body moving, where we can stress our cardiovascular system a little bit, walking, biking, swimming, dancing, keeping special consideration right to what some of those limitations might be in terms of our capacity for exercise. So if we're limited with our functional mobility, maybe we choose to do a recumbent bike, something that we're seated, but we can still get our heart rate up. Yep, Mark? Yeah, you have a question, Mark? Oh, okay. You're on mute.
There. I was just paying attention to my wife as she passed through the room.
Oh, sorry. I saw the hand go up.
Yeah.
So our aerobic activities, those whole body activities, the important thing here, right, is find something that you enjoy to do, right? This is kind of our long haul. We want that steady state activity, getting our heart rate up and keeping it up for an extended period of time, because we know what the benefits aerobically are when we go there. Find somebody to do it with, right? Get moving, find your flow, and continue to go. Resistance training, back to our 150 minutes, 2 times a week. Here's where our 2 times a week. So we're looking for at least 2 times a week, non-consecutive days. We need to incorporate rest into our physical activity journey. And then we're looking at 50 to 70% of a 1 rep max. So kind of similar or pretty similar to our, when we say moderate aerobic activity, we're looking at moderately stressing our muscular system through our resistance training. So about 50 to 70% of the most that we could do, starting with 1 set, going up to 3, and looking for 8 to 15 reps. These are pretty broad ranges, right? It's going to be prescribed, hopefully, by a therapist or an exercise professional, looking at large major muscle groups. Within that, right, our type is going to be pretty dependent on what our goals are and what our functional abilities are. So we can use weight machines, resistance bands, and then body weight activities too. So a lot of different choices here. The biggest takeaway is that we want to push some weight, right? We want to stress the system. Simply interacting with our activities of daily living doesn't stress our system enough to achieve the benefits of exercise, of physical activity. Flexibility is an important part of the physical activity program. So we want to do activities that promote our flexibility at least 2 days per week, 2 to 3 days, daily being the most effective. And we're looking for full range of motion, right? After stroke, especially if we have a hemiparetic side where we're limited in their functional abilities, that can be associated with the range of motion decrease as well. So finding ways to keep all of our limbs moving through their full range, holding static stretches for at least 30 seconds, but then looking at different dynamic stretches, different PNF patterns of movement, depending on what our specific needs are in terms of range of motion and flexibility. And then neuromotor, right? After stroke, our nervous system has been impacted, sometimes to a pretty profound effect. So finding activities that can stress and challenge our nervous system and our motor systems together through balance, through proprioceptive activities. These things can be quite variable and really a way to explore some different ways to move and take advantage of community too. So a lot of opportunities for classwork, things like yoga, Tai Chi, any balance, agility work can be really beneficial when we think about maintaining our health over the course of our lifetime, doing anything that we can to decrease the risk of falls. So these neuromotor activities are incredibly important from just staying safe and functional standpoint, interacting with our lives. So how to start, right? We hopefully talked about 150 minutes, 2 times a week being our baseline. Within that, there's nuance to the different modalities of exercise, looking at aerobic, resistance, flexibility, and the neuromotor activities too. The first thing to do is find some guidance, right? That guidance can come from different places, whether it's a primary care physician that's referring you to therapy, whether it's a therapist that's helping you start on that physical activity journey, looking to have a program that you can carry out at home, or getting you in contact with an exercise professional that might be able to better meet your needs. Finding somebody to help you on the right path, right? After stroke, things might look and be different than how they were prior to stroke when it comes to physical activity and exercise. Things have changed. We might need a little help finding the right way to do it. The community aspect is incredibly important too. Find somebody that's going to help keep you accountable, right? That can be a friend. It can be going to a gym at the same time. You see the same person when you check in at the front desk. It could be meeting a group of people. There's lots of different group classes out there that are available. Fun runs, walks, anything to stay engaged in the community, right? We get a lot out of physical activity, but when we're doing it together with other people, not only can it be more fun, but it can be really motivating and encourage us to maybe push ourselves harder than we would if we were doing it independently. And then find routine, right? It's got to be something that we can do consistently. The 150 minutes of aerobic activity, 2 times per week resistance training, that's not just every once in a while when it seems like it's going to work. We should be figuring out ways to incorporate physical activity into our lives, and finding that routine and making it just be a part of what we do is really important. Ultimately, it's finding your own path though, right? There's lots of different ways to do it. There's no right way. There's no wrong way. The bottom line is that you have to get out and get moving. So be encouraged that if you're out there and you're trying, you're getting benefit, right? If we're moving, we're seeing benefit. But if we can hit some of those thresholds, and if we can do it with some intention, then we can maximize the benefits that we know that physical activity can give us. But ultimately, it comes down to us as individuals. So I'll talk a little bit now. Sorry.
I know that building.
Yeah, me too. I usually don't get this view of it though. I'm usually looking out the other way. This is where I hang out 4 days a week. This is our gym. So I talked a little bit about some of those modifications, some of the environmental factors that can play an influence in our success in exercise after stroke. So I'm going to highlight just a few of the things that we have here at the Neuroscience Center that make us maybe advantageous leaders in prescribing exercise for stroke. So rehabilitation gym, parallel bars, adaptive equipment. I'll highlight down here, we have a track system, so we can do body weight supported work, putting people in harnesses over a treadmill environment or over ground. When I say adaptive fitness centers, our equipment at the Neuroscience Center, either the chairs can slide out so we can utilize them, the equipment from a wheelchair, or the chairs swivel. So we have different pieces of equipment that can be utilized for people with different mobility abilities. And then we have technology like FES cycles, functional electrical stimulation cycles, so we can stimulate paralyzed muscles after stroke if we have hemiparetic side that is unable to volitionally move through electrical stimulation. We can instigate that movement, increase blood flow. We have lots of different modalities to make exercise possible, no matter what the neurological condition is, no matter what the diagnosis is. Grip gloves. The grip gloves can help add resistance to a hemiparetic side that might not have intact grip. So when we're thinking about these choices too with assistive technology, assistive devices, we have to think about, are we promoting compensation? Are we promoting recovery? So if our goal is to work on grip, we shouldn't be using a grip glove. But if our goal is to work on our strength in our affected side, then yeah, let's throw a grip glove on and let's throw some weight on there too. So those choices that we make, the equipment that we use, is important to maximize the benefits from exercise, and it can be very helpful, especially as you get started, to make sure that you're talking with a therapist or a trained exercise professional to make sure that your needs are being met and that we're really taking advantage of all our exercise modalities as best we can. Specifically, at the Neuroscience Center, the program that I work in is called NeuroWell. In NeuroWell, we have different programming options. First, we have our small group exercise sessions. So small group exercise sessions, individuals come in with a individual scripted exercise program scripted by an exercise physiologist, with the goal of using our gym as independently as they can. So oftentimes they're coming with either a caregiver if they need a little help using some of the machines, or they're here trying things independently on their own under the supervision of an exercise physiologist. So our small groups are great for people that have finished therapy, maybe have a home exercise program, but aren't quite consistent with follow through, or they need some extra guidance as they continue to transition to home. Or for some of our individuals, this is their home gym. They come and work out and try to get those exercise guideline thresholds in our space, right? We can scale our programming up to an individual's needs. So those small groups are a good way to kind of bridge that gap between the one-on-one sessions with a therapist, as opposed to being a little more independent under the supervision of an exercise physiologist, but not quite ready to run the show completely on your own. We do offer individualized training sessions as well. So for people that would benefit from that more focused one-on-one training, so similar to a personal trainer, I like to think that an exercise physiologist is somewhere kind of between a physical therapist and a personal trainer, or we're not your commercial lifetime personal trainer. There's a little more nuance based on the complexity of some of these neurological diagnoses that we can hopefully meet people's needs in a different way with some of our different equipment, and hopefully some of our specialization. We have a brain gym offering. So brain gym is a virtual offering that's combination physical and cognitive activities. Brain gym sessions are led by a speech language pathologist and an exercise physiologist. Research has shown that our cognitive function improves when we move. So we've developed some programming where we do both cognitive activities and physical activities in a virtual group setting, which can be a great option for people to do things from their home. And then we have some Tai Chi balance movement classes that we offer in person in a group setting here at the Neuroscience Center as well. If you're interested in any of those, I'll flash this up at the end too, but neurowell@healthpartners.com is the best email to get more information on our programming, or you can call the number there to 651-495-6705. That is what I have to offer you today. I'll pop my questions up there. There's some references, and there's that contact info there too that I'll leave